Hey folks, my name is Dr. Amy Pearlman. I'm a board certified urologist with expertise in sexual, hormonal, and genitourinary health. And welcome to today's Pearls and Perspectives episode. And I have a special guest, Dr. Sijo Parekattil, on with us today. Sijo, say hello to the crew.
Hello, thanks for the opportunity and glad to be here.
The funny thing is, Dr. P, we met a couple weeks ago at the AUA meeting at the gym. And I came up to you because you were standing with some people that we both know, Dr. Raul Meehan and Dr. Kevin Zorn. And I went up to you and I gave you a hug because I felt like I knew you. And then I realized afterwards, I don't think we've ever met before, but you just have that aura or vibe about you that people just feel like they've known you forever. Has anyone ever said that to you before?
No, I mean, I hope I come across that way, and I think with social media nowadays, it's great, right? Because you get to meet people, not just their ideas, but you get a taste of who they are, right? So the same way when I saw you, I was like, man, you are so fit and even fitter in person. And so, I was struggling to do my chin-ups, and there you are powering away, and you're my idol. I look at your chin-ups, and I'm like, that's where I want to be. So.
I love it. At the AUA meeting, you kind of see who's moving and grooving by who shows up to the gym at 5 or 6 a.m.
Absolutely. There may be ulterior motives for social media, but hey, we showed up. That's the most.
I love it. So, I want to give a brief background of you for today's listeners because you have a very interesting background. You've done a lot of things, and you actually grew up in very cold weather areas, right? You spent some time in Albany and you're in Ohio, and now you're in Florida. How did you decide to kind of bop around a little bit?
Well, the thing is, I grew up in Zambia in Central Africa, and then my parents used to work for the UN. So when I came for school, I actually didn't like medicine, didn't like the idea of blood. I wanted to be an engineer, and so I was actually an electrical engineer for quite a while. Worked with Intel part time, and I was a VLSI engineer, kind of interested in micro kind of manipulation and testing. And so when I started to look at long-term careers, I realized that I felt like a number just working in the company, and so thought about how I could advance myself, and the only options are getting an MBA, doing my PhD, and then one of my buddies got into med school. So I thought that was great because he was like, "Look, let's go to med school. We can design instruments," and that was kind of my goal. I was gonna work for a tech company and make bioinstruments, and that was kind of my long-term goal. But as I started doing residency, fell in love with urology. It was just so weird and so different, and I had some infertility issues myself, and so I like the whole concept of guys helping guys in tough situations, talking about different topics, or difficult topics, sorry. And it kind of attracted me. So, and then I liked the urology resident that I kind of rotated with. I really looked at him as a role model. I still meet him at the AUA every once in a while, and he was just such a fun-loving, happy, positive guy. I felt like many of the other surgeons looked depressed, and I was like, urology is something special. There's something unique about it, and that's kind of how I ended up here.
I love that. We're so impressionable as early people on in training that sometimes all it takes is one person that greatly encourages us to seek a certain career path. And I think we need to know that that's very powerful for good and bad because all it takes sometimes is one person to discourage a certain career move. And you had that one person. I had one person too. I mean, there were many people, but there was a resident, Lambros Stamatakis, who's a urologist in the DC area. And one day he just was standing in front of me and said, Amy, I think you'd be a good urologist. And I was like, okay, I think I can deal with it.
Exactly, exactly. I mean, it has such an impact on you, right? I always tell people that you make the biggest decisions on the smallest things. It's not the big things that matter, it's the small things, and so that really drives the train and gets you going in a very unique direction.
Yeah, I love that. And you had the career of being an engineer, which if I were to have chosen sort of any background of knowledge or expertise, dang, I wish I had an engineering background. So, how does that background currently inspire what you do day to day in your urology practice?
Well, it's just it's that drive for innovation, right? That kind of push that, hey, how do we make this better? I think, I always say once an engineer, always an engineer. So when I tackle problems, I think of it very linearly, and it's never acceptable to just go with the status quo. It's like when you see something, you're like, well, how could we improve it? How could we improve the process? And so I think that's the same way I approach my clinic, and I really look at problems that patients are having. How do we meet that demand? And also with our unique setup, I'm private practice, solo. I'm kind of a rare breed right now, but I feel like there's a need because most of medicine is going to big medicine, right? Employed structured models, which I understand for efficiency, throughput, it makes sense, right? You want standardized care. But is standardized care really better? And I always argue that it's not, because I feel like, as individuals, right, you put on your set of clothes because that's you, right? You don't go in and buy a uniform and wear a uniform all the time, right? That's what creates your individuality. And the same way patients want to feel like they're treated individually, not like they're mass treated. And so I think what's going to happen is, sure, there's going to be a standardized care for everybody, but people will start to yearn and look for a little extra. And I'm hoping that we can be that little extra. And, I talk about you as well because I love what you're doing with Prime. And so, I feel and support physicians like you too, because I feel like we're a similar breed. We want to be different. We want to be unique. But more importantly, we want to find something that creates something rewarding for another person, right? It's so powerful when you meet somebody, you feel for them, right? Because they have an issue, and you're able to kind of work out a unique solution for them, because I feel like cookie cutter is always going to be cookie cutter. It feels like it, right? It doesn't, you can fit into it for general things, but it doesn't feel that comfortable. And so, how do we make healthcare comfortable, fun, exciting, not only for the patient, but for the physician as well? Because, both parties, it's a two-way street, right? If we're both excited, energized, I think that really leads to a great, outcome.
Yeah, absolutely. So, Dr. B, I recently had a very interesting conversation. I was interviewing Dr. Vonda Wright. She's an orthopedic surgeon and longevity specialist, and I was interviewing her. And I was hoping to get like these 30-second exit strategies. And so I said, like, Dr. Wright, what is your advice for the typical person who comes in, who's like a middle aged guy who wants to live his best life? And she was like, Amy, there is no typical advice. Like, that's like the premise of my practice is essentially precision personalized medicine. There is no typical. And so it kind of took me down like this whole other path of this conversation. I asked her, so what's your 30-second script for the activities that people should do, when they leave a urologist office? And she's like, there isn't a 30-second script, Amy. You either do it or you don't. Because in a practice, while we would like to say, look, you need to hit 100 grams of protein a day, that's your 30-second exit strategy as you leave the room. If we want to practice personalized care, we have to kind of go all in. Now, you were previously in academics, and then you worked in some other practices, and you started your current practice, Avant Urology, in 2020. Can you talk a little bit about that transition?
Absolutely, yeah. So, I kind of went through a few different positions. I started out academic. I was at the Cleveland Clinic in Naples, and one morning I get a text at 5 or 6 in the morning saying, "Hey, there's an emergency staff meeting. You got to report at 6 a.m.," which was kind of odd. We don't usually have meetings that early and stuff. And so I was like, "That's kind of odd." And I showed up, and there's a bunch of suits there. And usually at the Cleveland Clinic, we don't wear suits. We have our white coats and white outfits. And so I thought that was a bit odd. I was like, that's kind of strange. And I remember them telling me, "Hey, congratulations. We just sold you and the hospital to HMA, and congratulations. This is your new employer." And I was like, "What?" I was like, "Can somebody do that?" Like, and I had just come out of fellowship for 2 years. I had all these dreams about working in the Cleveland Clinic, Naples and stuff. And I'd been so you buy into the vision, right? And the vision is really just being better, building something better. Nothing wrong with the Cleveland Clinic or anything like that, but the issue is the fact that I had so much or such a lack of control, and in a moment, I was just sold to a for-profit entity, and they're my new employers. Sure, they give us a bonus and thing, but it didn't give her that feeling of just, wait a second, what's our goal? What's our mission statement? Like, who are these people? Like, do I even know these people? Like, do we even think alike? Or, what's the story here? So it was a tough pill to swallow. And I was soon out from fellowship. So very idealistic. I wanted to do more research. And so I felt like this wasn't my cup of tea. So I moved to University of Florida, stayed there for about 4 years. I started to develop an interest in chronic pelvic pain. I remember my chairman telling me, Sijo, stop right there. My pelvis is hurting right now. And it's like, so he was like, you're not going to make a future in this. And there's no future for this. But I quite, I just quite disagree, because these niche fields and unique conditions really have an unmet need, because most physicians don't want to deal with patients like this. And it's unfortunate, because for the patients, they're struggling. They go from physician to physician, and it's difficult to find somebody they connect with. And so I felt like there was a need, and that's what kind of got me into that direction. I then started a program for them in Winter Haven, hoping I'd get a little more freedom, because I always wanted to use the robot for microsurgery. And as you know, it's very difficult for microsurgeons to get access to the robot. When I did my fellowships, I did dual fellowships, one in oncology and robotics and laparoscopy, because those are the only specialists that got access to the robot. And then I did a year of infertility and andrology, but my plan was always to use robotics for microsurgery. So during this growth period, I was always kind of the junior staff, never had that kind of authority to drive the direction of research in one area. So I went to Winter Haven because I was basically starting the program there. So I was really able to kind of grow and develop it. But 3, 4 years later, that hospital got sold to another entity. And again, all those relationships I built with administration, with upper management, all went out the door, right? And so then I moved to South Lake Hospital here in Orlando, because they were 51% private. And so I thought, okay, great. I found a safe landing spot. And they were like, oh, yeah, we're a community hospital. We'll never sell out. This is what we're meant for. And so I had a great practice there. Started with Dr. Brombod, and we had a great time. But then again, that hospital got bought over by Orlando Health, and I had to sign a non-compete, which was like the most ridiculous thing. I'm like, wait a second, I live in this town. Like, I've been here for like 4 or 5. Why am I signing a non-compete with this new entity coming in? So that's when I realized, I was like, you got to take care of yourself, right? Because no one is really going to take care of you. And at the end of the day, even for the patients, if you really believe in something, want to offer something unique, you need a stable foundation, and a foundation that you can grow from, that can grow to your specifications, because everybody's different, right? You're like a tree, like growing, and you want to spread out. And so that's when I thought, okay, this is the time I'm going to do this. And even my parents were worried. They were like, are you sure? Because I broke all my 401s, every penny I'd ever made, broke it all. I really followed that principle of, hey, invest in yourself, right? So I put everything, built my own building, office, everything. And it's been the best thing I ever did, because I'm able to really offer cost-effective care. It's got me thinking differently, because when I was an employee, sadly, I didn't care about how many gloves I used or how expensive something was, because that was somebody else's problem, right? So I never, so in a weird way, I don't blame anybody else except myself, because I was so spoiled, so used to having everything done for me, that I just forgot what it takes to earn that, right? So how much work do you have to do to pay for that glove, right? How much work do you have to do to pay for that ultrasound machine? That's a whole different ballgame. And when you have your own practice, all of a sudden now you're very cost conscious, you're very efficient. I'm always worried about how much it costs for my patients. I remember patients getting annoyed at me because they'd get their bill from the hospital, and it was like this ridiculous bill. And I would even try to look at it and I couldn't figure out what was what. And I was like, I'm so sorry, but I have no clue about this. This is beyond me. And so, but the sad truth is now I have control of that. Like I tell people this is the price. Like if we're doing something it's not covered by insurance or anything, I have a fixed price. It's like going to McDonald's. There's no bartering or any weird stuff. It's very legitimate, upfront, transparent. Everybody's happy because you know what you're getting. There's no secondary bills or tertiary bills. And again, it took me taking ownership and doing it, right? Because it's not somebody else's fault or somebody else's blame. It's really my own fault. I don't know why it took me 20 years to wake up all of a sudden and do this, but it's been so liberating. And even for my patients that have stuck with me, I've got some patients, from Naples that still come and see me, and it's great, because they can see my evolution. And at the end of the day, I don't think any of us got into medicine because we want to hurt anybody. There's a fundamental need to love and care for somebody. And, you know, I didn't really want to make money. I mean, obviously it is important to run a successful business, but if that truly was my goal, I'd do something else, I'd be in business or something like that. But my goal was really, I just want to have fun and help somebody and solve somebody else's problems. And so at the core, I think most of us physicians feel that way, but we've been vilified, we've been objectified, we've been restrained, we've been boxed in by certain institutions and paradigms that we're losing ourselves, and that's why there's so much physician burnout and all this stuff. And also patient dissatisfaction because they feel it too. They feel like they're just a number. So how do we get it back? I truly am a strong believer in private practice and independent practice and having that freedom to really go where the patient wants to go. And that's ultimately what it's all about.
Yeah, it's so interesting because we're kind of, you know, like a few years ago, no one was like a solo practitioner. We were moving so far away from that. And now, kind of like the pendulum is swinging a little bit. I think both of us have seen more and more of our colleagues start their own practices. I love what you mentioned there in terms of cost transparency. And I think what both of us have seen and both of us have been surprised by is how inexpensive and expensive things may cost. I think both of us had probably been surprised at how much a Euroflow machine is, a bladder scanner. How does that cost $5,000 or $6,000? I had no idea. I thought that would be way cheaper. And yet I'm surprised at how cheap lidocaine is and disposable scissors and absence and suture is. So again, like you, when I was in a bigger practice and had no control over the pricing, and I had a patient who didn't have insurance who wanted a simple frenulectomy in the office. And I had to tell my patient it was going to cost him like $5,000. And when I went to my admin and I said, I don't understand the 5,000. This is what I need. I need one suture. I need 10 cc's of lidocaine. I need disposable scissors, right? And like some betadine and 30, maybe 10 minutes of my time. That doesn't cost 5,000, but I had no leeway. So now in my current clinic, because I know all the prices, I can come up with a price that actually makes sense.
Yeah. Yeah. And I think that people demand that, right? Because they're tired. They're leery. They're afraid. The moment you mention procedures, things, that's the first fear. Everybody's, it's my fear. And I go to the hospital, I'm like, how much is it going to cost me? Like that's the first thing that comes across your mind. And we're just normal people, and so that's everybody's number one fear and concern. And so I think that transparency, there's no reason why we shouldn't have it. And I think the only way to fight back is, unfortunately, through direct care models and private practice. And it's happening. I mean, we can see that, there's individuals that like the employed system, and we need that, because you need hospitals, you need emergency rooms, you need 24-hour service. So that's never going away. It's just that how do we make the overall system better, right? It's some type of hybrid system that has both. And I think that's what's happening. That's happening with you and me and a lot of physicians out there. But at the end of the day, it's about one thing and one thing only: the patient. How do we get a better outcome? How do we solve the problem? And as long as it stays true to that, that's when everybody's happy, you know.
Mhm. So I know you're not actually sitting in your parking lot with your building behind you, but I want you to give us a tour of your building. When was this a build out? How did you find the location? And what do the rooms look like? How did you design the rooms?
So I wanted it not to feel like a clinic, right? Because I don't know what it is like in general, urology clinics or clinics in general, there's like a smell, there's a feel to it, right? And it's always that old, kind of like not super modern look. And that's your
Maybe a
typical.
touch of urine smell.
Exactly. Like there's like a hint of it, and it doesn't smell clean, because I don't smell the fabulosa, so it's just not clean. And so one thing that people will notice right away when this you're gonna smell fabulosa, so it's just that we have our cleaning crew clean it thoroughly with you know really strong stuff, fabulosa, whatever it is, Clorox, whatever, just stuff that really makes it smell clean, bright. And the moment you step in, it's got to smell good, right? And then we're not cheap about drinks and snacks and things like that. So we have a bunch of drinks and stuff that you can, you know, feel free to take. Now some patients overindulge, but that's okay. That's how nature is. We're here to serve the bell curve. So we're here to serve everybody. But it's just a nice feeling. Just not a stingy feel, right? So how do you make that warm kind of feeling? And so we were very blessed to have a great architect who helped build the building. Um, Everything, I love the Florida skies. So every room, exam room and procedure room has a skylight and a window that kind of looks out to the sky. So that way, more the interior workrooms are more in the middle, but the patient center rooms all have a window. Well, kind of like a skylight. So for privacy, it's like just a thin strip, but it makes such a difference when you can look over and see the blue sky, and it just sets a different tone. We got floating cabinets, like I see you have too, with under lighting and stuff. And so spaciousness, right? Just that feeling of endlessness and limitlessness, right? The wall design is an organic, like cement-based thing that is just free form. So every room has a different look and feel. I want each room to be different, and so not the same. And so that's the general experience. We have a bunch of pre-med medical assistants that work for us, and the reason we choose them is that I love people that are heading someplace and going someplace and want something better, right? Every person, right? If I wasn't looking to improve myself or make something better, how am I going to do that for my patient, right? And so same right from the front desk person, we have individuals that are shooting for the stars and going some. This is not going to be their forever job, but this is a stepping stone to something even better. And that way everybody cares, they have a pulse, there has there's some meaning to this, because for the medical assistants, we wanted to give a concierge experience. So one MA is with that patient from the beginning. They go through the exam rooms to check out, and so it's kind of a nice tight kind of service, so that it's the same person you're dealing with from the beginning to the end. And then we have it workflow designed so that it's just kind of in one direction. And then the procedure rooms, maybe I spent a bit more than I should have, but they're just top technology. I mean, we have the OR1 system in our, I basically have two mini hospital ORs in the office. And the reason is I do a lot of microsurgery with the VTOM system. We're one of the only offices in the world with the VTOM or one stored system all in an office, and so everything is like 4K, 3D. I've got 85-inch Sony 3D TV. Like I got these TVs on the ceiling, and I didn't realize how difficult it was because these are big TVs on the ceiling, and so there's a huge liability issue. I thought it was a cool idea. I copied from my dentist's office, but actually implementing it and getting a real big, 40 or 50-inch TV there is a whole other story. And so we had to fly in an engineer from Chicago because there's only a few of these engineers who are certified to do the soldering and the support structure for such TVs and stuff, or anything, any heavy items like that, because the problem is liability. Who's gonna be liable for it? So it ended up being a very, very expensive project. But for the patients, I think it's great. We play TV. Usually I play a lot of Bob Ross to make it a very comforting, welcoming kind of atmosphere. So patients can watch that. They have their own customized music. So every room has its own system. So basically, the patients can talk to Alexa and get whatever music they like, because it's all about them. And then we pipe that through, so we kind of distract them as much as possible. And then we focus on our procedure. They can watch it if they want to, if they're awake, or we can play something else, or they're out with IV sedation. So I have our own CRNA, so we can do IV sedation, nitrous. I'm the biggest baby. I don't like pain, so I treat everybody the same way. I want everybody to be totally comfortable, and if they don't like something, they can be asleep. So it's their choice, and so that's how it's structured. So it sets a very nice vibe, and that's the basic foundation of it. And then we just have a great crew. I was very blessed. I had a PA that I used to work with back in Winter Haven. I couldn't work with him when I left the other place, but somehow the stars aligned and he's back with me now. And so he says he wants to retire with me. I hope so, because I don't want a lot of staff rotation. I just love having the same people. And then we're very blessed. We have another PA who's incredible, and she's just we really feel like a family. So we're small, but we have a lot of fun, and I think that way, hopefully that atmosphere transmits to the patients. I've been in offices where you can feel the tension, and you can feel that people are unhappy, and we really try to not create that kind of environment, and hopefully that the patient gets a better vibe.
I love that. The devil is in the details. As soon as someone walks in, one of my favorite questions to ask my patients, would you like some water? And then if they say yes, would you like room temp or cold water? And I love asking that question. And I think just that simple question, what temperature do you want your water? They know I'm here for personalized care.
Yeah, it makes a difference. It's the little things that matter.
Yeah. So I want to delve into some of the innovative therapies that you're offering. And actually, you and I got some differing advice when it comes to male pelvic pain, because you were kind of told, what are you doing? Like, you're not going to be able to build a business doing that. And one of my mentors was Alan Ween, and then Dr. Carl Creeder was my chairman at the University of Iowa. And kind of both of their sentiments was, choose something to specialize in that no one else wants to do, and that's how you will grow your name. If you want to specialize in prostate cancer, essentially good luck, because everyone does. But if you want to specialize in like interstitial cystitis or nocturia or something like that, then do it, because a lot of people don't care. And we got kind of like differing advice there. And so you've chosen to really be innovative in this space that, as you mentioned, most urologists, most healthcare providers have no interest in seeing those patients. So talk to us a little bit about, what are some of the innovative therapies that you're offering for chronic testicular pain or scrotal content pain and male pelvic pain?
Well, it all starts from something called the trifecta. So it all started because I had a patient who came to me with such severe testicular and groin pain. He was like, "Look, just take my testicle off. I want it off. I'm done with it." And so, I was kind of shocked, because the problem is I was worried about phantom pain and issues like that. So I told him, "Look, what if we do a little study, and can I do some biopsies on your cord and try and figure out what might be wrong, and if there's any abnormal nerves, we'll cut those, and that makes more logical sense. And if I fail, then I'll take your testicle out." So we had a deal. He was like, "Sure, go for it." And so initially, these procedures would take me about 6 to 7 hours, because I had a pathologist I work with. I would do real time intra-op sampling. I'd give a small sample of the cord, the cremocerix, the perivasal tissue, the perivascular tissue, the post. It was very painstaking. And we did 50 or 60 of these cases. And basically, and I had some healthy controls, guys who I was doing a radical orchectomy for cancer or a varicocectomy who had no pain, and they agreed to letting me sample their tissues additionally for the study. So they were my healthy controls who had no pain. And what was amazing is we found that it's not in their head. There's a structural difference between men who have pain versus those that don't. And it was very reproducible across different types of patients, patients who are idiopathic, no known cause, post vasectomy pain, post hernia pain, chronic recurrent epididymitis, chronic prostatitis. So you can lump all these guys together. And what was interesting is the pattern of Wallerian degeneration. That's basically Wallerian degeneration is basically a lining of the nerve gets damaged. So think of the nerve as a coax cable, and the outer part gets damaged. So these nerves become hyperexcitable. So we know from the neurology literature that if you have Wallerian degeneration in your arm or your fingers or your leg, you can develop chronic pain. So I really believe that chronic testicular pain is another variant of that type of neuropathy. So there's something wrong with the nerves going down towards the testicles. And once they get triggered, it's difficult to turn them off. And so this is the first study that shows that patients are not crazy. And it's the only prospective randomized control trial that looks directly at tissue from guys with pain versus those that don't. There is no other study like that, really looking at these people head on head. Took a lot of work, and then we did some cadaver dissections to confirm the location of this, but we came up with three areas. The cremasteric muscle layer around the spermatic cord, the sheath around the vas deferens, and the posterior fat behind the cord. These three hot areas had the greatest degree of these abnormal nerves with Wallerian degeneration. And so we hypothesized from that when you do a denervation procedure for the cord, there is no reason to get anywhere near the blood vessels. Most of the nerves are not around there. They're really around the cremasterics, the perivasal sheath, and some of the fat behind the cord. So when we basically developed a procedure called targeted denervation of the spermatic cord, where all I do is I cut the cremasteric muscle layer, the sheath around the vas, and some of the fat behind the cord. And now it's evolved into a procedure in the office that takes 20 minutes skin to skin, just under IV sedation, very simplistic case, and really has minimal side effects. The whole goal here is to minimize the risk of losing a testicle. You know, we've done about 3,500 of these now, the world's largest series. We get guys that come from all over the world. We have lost 3 or 4 testicles. That's the worst thing that's happened. But these were individuals that had prior surgery, usually some pre-existing conditions and some issues. But, you know, nothing in life is perfect. So, you know, we'd be forward and upfront that, you know, we lost 4 out of 3,500. So, so still a very, very low testicular atrophy damage kind of rate. The success rate overall was about 86%, and that's based on the COSI, the validated and standardized COSI questionnaire. And that's just a questionnaire that measures quality of life, pain, and sexual function kind of all combined together. And so this is really kind of validated data. So it shows that there is something real to the denervation procedure. So that's our number one procedure.
Well, I want to ask you some follow-up questions on this. Is that okay? All right, cool. So does this necessitate a micro Doppler, like an ultrasound?
It does help, you know, because you're staying outside the internal spermatic sheath. The requirement is definitely a lot less because we're not dissecting, you know, kind of like Dr. Larry Levine came up with the original denervation procedure. So for that, you definitely need a Doppler because obviously you're dissecting around the blood vessels, then you should. But with this, you could get away without the Doppler because remember, you're going to leave the whole internal spermatic sheath intact. So you're not going to play around with the blood vessels at all. Just leave them intact. Because my feeling is it's not worth the risk. Because the more we mess with the arteries, at one of those times you're going to hurt the artery and stuff. So if we can keep it intact, that's usually the best issue.
Yeah. Well, we see these great pictures, photographs of intraoperative, you know, cores that have been denervated, and you just see like 1 or 2 lymphatic channels. You see like the artery, you see the vas.
The first thing I think about is this whole testicle's hanging on those 3 little.
Yes.
It's like I think like I mean talk about torsion, man. Jesus, like all it would take is like a half turn or something, and you know it'd be toast. And so I feel like the whole structure integrity of the testicle is keeping the vas intact. You know that brings a lot of strength. and then also keeping that internal somatic sheath intact, so then you've got some strength to that cord.
So then this means you don't need a microscope, a surgical microscope.
You could get away without it.
Yeah.
It is always better with a microscope,
Mhm.
just because, to differentiate between internal somatic sheath and that cremasteric muscle layer, especially in the skinny guys or guys that are not that large or have a small cord, it is tricky. So I always recommend the microscope for sure, but the Doppler, because you're staying totally out of where the arteries are, we should be okay. Now obviously you are sacrificing the arterial supply in the cremasteric. Some of these losses that we've had, I think, are in cases where maybe the cremasteric was the primary blood supply of the testicle. And so, for any unknown reason, the two other arterial supplies within the internal somatic sheath may have been damaged. The perivasal artery may have been damaged. So, we don't know. But so, usually you've got three supplies, right? So, it
Mhm.
should be okay if you take the cremasteric. But that's why, technically speaking, you could probably get away without a microdoppler. But the microscope or loops are helpful, I think. And some type of magnification probably is helpful
Mhm.
when you peel off that cremasteric muscle layer.
So are you sparing the perivasal artery?
Yes, I am. So I try to keep the deferential artery intact,
Mhm.
and I'm just taking the light fascia around the vas.
Mhm.
Over the years, I've become more and more conservative around the vas, especially a younger guy who's in, fertile age who wants to have kids. I'm very, very delicate around the vas because the highest density was actually right in the cremasteric muscle layer. And that's why Dr. Kavusi, Parviz has come up with, a cremasteric muscle ligation
Mhm.
it also works fairly well because maybe that's the key item, and so I take some of the fascia just around the vas just because we found some data there to back it up. But I can understand how patients would probably do similar by just taking the cremasteric. And so I think the cremasteric muscle is the main culprit in this. And a lot of these guys, especially, will complain about having a hyperreflexic testicle that kind of pulls up into the testicle and it's kind of tight and they feel that tightness or kind of it's sitting in the wrong position. That's all cremasteric dysfunction because it's giving them that sensation, giving them that pulling, tugging sensation. So a lot of guys, once we get rid of that feeling, they feel great.
Yeah, I've selectively divided the cremasteric fibers, just doing that, and I've noticed some benefit in the properly selected patient. So let's say a guy is not interested in future fertility. Are you then taking the VAS or are you still sparing it?
I always spare it because, I'm always worried about, then there's the whole category of post vasectomy pain syndrome, right? What's causing pain in those guys? Maybe it's some type of obstruction, in the vas. And so my feeling is it's better not to mess with the vas because there's some guys when we mess with the vas, they get pain. And so why create another potential area? Like, I think nature was meant to flow and it's always good to let the flow flow. So I say always preserve the vase. I think it's better not to ligate the vase.
Okay, so let's talk about the guy before he, let's say, ends up in your procedural room for a, selective cord denervation. How are you doing the workup to know whether or not he might benefit from that procedure?
So classically, we do a cord block. You can do an injection with lidocaine, marcaine around the cord area. But the problem with the cord block is if you don't hit the right spot or miss the nerve, you could get a false negative. And so a lot of times now I'm skipping the cord block and you can go straight for the denervation. And the new AUA guidelines incorporates some of that thinking process and that the cord block is not the end all be all. It is helpful, but it's simply a predictor. So we looked at our own data. If you respond to the cord block, there's an 80-90% chance that denervation would work. But if you get a negative result, there's still a 60-70% chance that the denervation would help. So why limit somebody who may benefit, from that procedure? Because by the time they get to me, I'm the end of the road. And so I really don't want to do a lot of procedures with these individuals. We really just want to help them. And the cord block is not usually a therapeutic option. It only lasts for a few hours or a day or two, and then the pain is back. So my feeling is a lot of times I if they've run out of all their options, and usually they are by the time they see me, they've had all the imaging, we've ruled everything else out, they've done pelvic floor therapy, biofeedback, all that kind of stuff. So, we're at the surgical stage. Then I feel like there's no reason to putz around. Let's go straight for something that's going to help the patient. And then I inject Exparel and Marcaine at the time of the denervation procedure. So I kind of get a pseudo cord block right after anyway, because I'll know, because if they tell me, yeah, for 3 days I was great, and then the pain started to come back, then I know that they're responding to blocks, but they're not responding to my denervation or so. And so then the next step would be targeted cryoablation. That's the next option. And that's where I knock out a few more nerves. We kind of go outside the cord, two little incisions, we come around the cord, and then I hit the illingual nerve up high near the hips. And so that's the next step. And then if that doesn't work, I do Botox injections. Some works really well, into the cord and the premotoric muscle area or around the cord. And then if that doesn't work, we do low intensity shockwave lithotripsy. If that doesn't work, then orchiectomy is always there at the back of the options. It does work in selected individuals, especially if they respond to these blocks temporarily and then the pain comes back after these procedures, then an orchiectomy definitely makes sense. I'm not the biggest fan of epididymectomy, where you just remove the epididymis, just because I've had one or two guys where their pain got immensely worse. And so then I think it jades the system, because the patients lose patience and they're really like, oh, just take my testicle out now, just take the whole thing out. So I feel like epididymectomy, even though it works for some people, is like heading straight towards orchiectomy. And so, I think there's much less invasive things like denervation and cryo and Botox that we can do that may offer a less invasive option, before we jump into cutting things out.
Yeah, I tend like you to stay away from the epididymis. But what if someone has, I don't know, let's say like a 1 to 2 centimeter epididymal cyst and they have point tenderness in that area? I personally tend to stay away from the epididymis and address the cord. What are you doing in those scenarios?
It still feels better to stay away from that cyst, because what I tell most guys is, let me do the denervation. If it doesn't work, then we'll come after this. But because there's a really high risk of making things really bad. I get a ton of consults for patients who get epididymectomies and epididymal cyst removals elsewhere. Then the pain gets worse. And then now they're just more kind of, they really want something done right away, because the pain is really bad. So that's why I feel like there's more science-based approaches out there with, we know about the nerve dysfunction. Let's target the nerves. Let's calm them down. I think it's much more eloquent, much more targeted, and a lot less morbidity for the patients.
And have you ever done like the cryo and or Botox before the cord denervation?
Sometimes you can, so there's some individuals that, let's say they have more groin pain, right? Post hernia pain. It's kind of near where the mesh is and higher up. Those guys, I'll usually jump straight to cryo, because cryo, I can hit those spots and I go straight for those locations. I use Botox for guys who don't want any surgery. The guys that walk in says, I don't want anything invasive, just my mind's not wrapped around this thing, So then Botox is great, because if they get relief and lasts only for a few months, then by the time they come back, then they're usually ready to do something more invasive. However, having said that, I do have one patient. He came from London, and we did one Botox, lasted for about 6 months. He flew back in, did another one, and he's about 3 years out. He's pain free. So Botox does seem to have a cumulative effect in testicular and groin pain. I don't know why, but it's not like other areas where you have to do it every 3 to 6 months. It seems like the effect lasts longer and longer each time that we do it. So there is some benefit to Botox, and I do think it's not a bad option. It's definitely should be in the armamentarium.
Mm-hmm. Awesome. All right. So I cut you off before, but you were going to get into some of the other innovative therapies that you're offering.
Oh yes, yeah. But I think we kind of circle back. So targeted denervation, the cryoablation. Cryoablation is something that we developed, so no one was doing it before. There's a few places doing it, but it's really cool. We used to use the Galil needles, which are very expensive, and so we use the Cook endocervical cryoprobe. They have a micro probe for that. So we just make a 1 centimeter incision, then we tunnel that under the skin towards the nerve area to ablate. And it's very cost effective because it just runs off of nitrous gas. So it's a reusable tip that can be autoclaved. So again, really cost-effective medicine. So I was able to bring the cost of all these procedures down just to like a few $1,000s each. From when I was at the hospital, it was getting like 20, 30, 40,000, in that range. So, much, much more reasonable, and within the reach of many people. So, that's one direction. I do have some exotic stuff with, I've been using a lot of low intensity sound wave therapy. I really do feel like we underutilize it. I'm a big believer, like Rachel Rubin and stuff. And so I use it a lot for groin pain. It can be very helpful diagnostically because if patients respond to that, and it's non-invasive, if they respond to that transiently, it's almost kind of like a cord block. Then that, hey, this guy is probably going to do well with targeted denervation or cryo. And so low intensity shockwave has really become a big part of my practice. And even for chronic prostatitis, a lot of times patients come in and they have a multitude of symptoms, right? It's not just testicular pain. It's perineal pain. I feel like I'm sitting on something, some frequent synergy, some urinary symptoms, but they're 20 years old. You don't want to cut on this guy, so low intensity sound wave is amazing for these patients because you hit the prostate, you hit the penis, help with the ED, you help with the groin pain. It has like a multimodal kind of approach. And so I love low intensity sound wave therapy. We
So, real
also
quick follow-up question. So, when you're putting the probe on different areas of the genitals, are you putting it like at the external inguinal ring? Are you directing it to the cord? Are you putting it on the testicle?
generally in the external inguinal ring, the ilingual nerve near the hips, and then you can even do one location near the nerve roots in the back, where the ilingual nerve takes off, from the spinal cord area. That's a little bit trickier for us because we don't really work in the spine too much. So I pretty much stick down to the anterior, just ilingual, 2 finger breadths medial and inferior to the ASIS, and then right where the external ring is, where you can kind of put your finger in there, and right above that. And then we'll also always treat the prostate a few hundred shocks down there because I feel like the prostate is always involved. There's some component of that. And so those pelvic nerves are definitely jacked up. So we always do some treatment to the prostate as well. And if they have any ED issues, a little bit of treatment to the penis as well, because improved blood flow there only helps. And so we kind of treat kind of that global approach.
Yeah. I love targeting the external inguinal ring because that seems to be a big pain generator for a lot of people outside of someone having a hernia.
Yep, it's a
Yeah.
huge area. That's also where we target with Botox.
Mhm.
So I think that's a prime location. Another very unique thing we've done is I kind of stole this idea from Optilume. We do paclitaxel bladder washers. So just pure paclitaxel, 6 milligrams, mixed with some lidocaine, marcaine, steroids, and it's amazing for overactive bladder and IC patients. And I feel like the reason Optilume has had so much success for BPH treatment is not because of the balloon, because we've had balloons for centuries. And why is this balloon work so much better? And I truly think the secret sauce is the paclitaxel because not only is it getting into some of that tissue in the visual line, but it's also getting into the bladder. And the bladder is a key player to a lot of these issues. And we kind of overlook it. And, I really believe in what Wayne Kwong is prophesizing with his defend the bladder kind of movement. And so, defend the detrusor. I think the bladder is overly ignored, whereas that's an equal partner in crime and that there's usually some bladder dysfunction. So mixing in a paclitaxel bladder wash, we do that like maybe once a month, depending on how patients respond. Some patients love it and they kind of auto treat. So they kind of set up their own algorithm in terms of how often they like to do it and when they want to do it. And it's very cost effective and very simple. We actually use the Urodapter so that we don't even put a Foley or a catheter in the urethra. You can just use the Urodapter up to the opening of the urethra, and we just squirt the fluid in. So that way, really kind of going for patient comfort. So the less we stick things into places we don't want to be or where the patients want us to be, I think the better. So we try to make it as comfortable for the patient as possible. So that's also some exciting stuff that we're doing. Some off-label stuff that we're doing. We're using the echo laser. It's usually used for focal ablation for prostate cancer, but I'm using this off-label for some patients with chronic prostatitis as well. And so there's some applications there because you can target where the nerves kind of enter the lateral lobes of the prostate. And so we just do two little ablations along that zone, and it seems to work fairly well. So we've had some success in some patients with that as well. So that's some of the, you can kind of see there's a lot of my engineering stuff kind of coming through in some of these things that we do.
I love that. So, getting back to the last technology that you were discussing for chronic prostatitis patients, describe a typical patient that you think might benefit from such a treatment.
You're talking about the laser ablation, right? The echo laser, yeah. So this is the individual who's had some transient relief to the low intensity shockwave literature that we use ViaSure. But so those are the guys that seem to get some help with pelvic floor therapy and with low intensity sound wave therapy, but it seems to be refractory, right? They get better for a while and then it comes back. We've tried intermittent therapy where we do a little shockwave like every 2-3 months, like, a few, like 2-3 weeks, and that seems to help. But could we get something more long term, right? So they don't have to keep coming back to that treatment. These guys do really well with targeted laser ablation, because they seem to have recurrent pain that or symptoms that seems to occur in that manner, and they seem to respond to low intensity sound wave therapy. We can also try a targeted periprostatic block. So if they respond to a periprostatic block, those are patients that also do really well with the targeted laser ablation because you're kind of giving it a dry run. I'll actually inject some of the material into the prostate, into those lateral areas, just to see if really hit those spots and see if it makes a difference. Because if they respond to the injection, then they're more likely to respond to ablation as well.
Any concern with erectile dysfunction?
Thankfully, we stay well away from the neurovascular bundles. What's really unique about echo laser is that we do real-time Doppler assessment while we're doing the treatment. So I actually look at I kind of zone in on the neurovascular bundle and have it there on my screen. So I'm actually looking at the neurovascular bundle, and then I do my treatment around that. So if we focus it that way, we'll never cause any issues, but that's always the main goal is to don't ever cause any harm, right? So we don't want to make anything worse. So I'll kind of zone in on that, then do an ablation as close to the lateral edge as I can get without affecting blood supply in the neurovascular bundle.
So, you're doing a lot of innovative things in a essentially solo urologist practice. What is your message for other people who, let's say, are early on in their training and they want to be curious and creative and contribute to research? And you're also the president for the Florida Urological Society, but you're a private practice guy. What's your message?
I would say always go independent, right? Like always be your own person because there's no one out there that understands you as well as you understand you. And there's no one out there that's going to deliver the level of care that you want to, because that's your touch, right? And the moment you appreciate that, understand that, you're going to be way happier because happiness, right, is based on expectations and the lack of achieving those expectations, right? But if you're the one that's the boss basically and you're setting your own goals and expectations, right, you have no boundaries. You really are, it's really just you didn't do the work or put in the time and effort or have the finances, but it's very
We're
simple.
the only people to blame.
Exactly. And so there's really no one else to blame, and so it really is the key to success and happiness, right? Because I went from just complaining about everybody else to being like the happiest person, and after I got written up so many times at the hospital for my bad behavior, I realized that, I think the hospital assigned therapist was the one that told me that, hey, maybe you should be on private practice. I don't think you do well in a cage, and she was absolutely right. I think it was like the best thing. So my message would be, don't wait 20 years, do it now. It's difficult, it's hard, but it is so rewarding and it's totally you. You'll be totally happy. And at the end of the day, what is life really about? Happiness. And if you're not happy, there's no way you're going to make your patients happy.
So let me ask a follow-up question here because I really love that message. I've given talks before on starting like a concierge practice, and I have so many people that come up who are currently residents or fellows, and they say, "You have my dream practice. I want to do that as soon as I finish with my training." Now, my message for them is I want you to have your dream practice as well, because like you, I'm super happy in my current practice. But you need to put your time in somewhere. You need to build your expertise somewhere first before you're a solo urologist trying to build your practice.
And I think that's an excellent point. I think you can't start from zero, right? So everybody knows the first few years, unfortunately, are rough, no matter how good you are, how perfect you are, how well trained you are. Everybody has to go through that learning process, right? You learn a few things. Nothing beats experience, right? So, I would say 3 to 5 years of experience, figure out what you enjoy, right? Because do everything, right? You're under the protection of a big institution, or that's the time to explore, define yourself, figure out what you like, what you're good at, what you're not good at. And then once you've got that under your belt, during those first 5 years, try to save up as much money as you can. The frustration and the desire to buy big, expensive things is always there. But if you can somehow allay that a bit and just put some money away for your practice, so that you don't have to borrow as much, it makes such a big difference. And so those are the best piece of advice, and it's hard because everybody coming out, you're so beat. The last thing you want to do is delayed gratification. You want instant gratification. And so it's very hard to go from instant to delayed. And so, but that's what private practice is. It's delayed versus instant gratification. You have to learn to pace yourself. You're not going to be the expert, the number one person on first day. It's going to take a lot of time and effort. But yeah, there was, one point where we were about maybe half a year into this where, we were just totally broke. Bank accounts, everything down to zero. We couldn't even go out to eat and stuff. But then after that tough period, then it started to get better. And so you unfortunately have to hit a bit of rock bottom to then start to go up. But if you plan it well and you save ahead of time and you know that in 5 years this is what you're going to do and you plan for it, you can probably get away without hitting that rock bottom and it won't be as rough. So it all comes down to that self-discipline and putting that money away for you, because that big salary is really not a big salary. It's just smoke and mirrors, because it's programming you to, kind of follow that little nubbin, right? And it's not really you. That's not who you are, And so till you figure that out, who you are, right? I mean, I think it's always better to go private, 5 to 10 years after you've got some experience, you got your family established, then it's time to really do some personal wellness, well-being kind of treatment stuff. And that truly is when your job becomes your therapy, that is amazing. That's amazing. You don't need to go outside to get therapy. It's like just doing what you do is therapy, and that's great. It's like that's when you hit that mecca.
I think our parents probably had the same shared fear, which is, Mom, Dad, worst case scenario, I move back in with you.
Exactly.
I love it. Well, thank you so much for sharing your expertise today and all the innovative therapies. There were certainly some things that you said today that immediately is going to change how I discuss certain options with patients. So, where can people find out more about your practice and what you're up to?
So you can always look us up on our web, avanturol.com. And then we're on Instagram, at Dr. Parekattil. I know it's a tough spelling, but there's not too many names out there like it. So, or Dr. P. And then on YouTube, Instagram, and LinkedIn, we've got tons of material. And, I post a lot. So that's really where the bulk of our education occurs.
One last question. What is the next exciting thing that you're looking into?
I really feel that laser ablation for prostate cancer is the future. Um, President Joe Biden, we dropped the ball. He is unfortunately a prime example of a typical male and our current state of affairs with healthcare. Guys, we don't want to go see the doctor, and it's too easy to hide. And the insurance companies and the government just don't want to pay for what's good for us. So it's very easy to sweep it under the carpet. And I feel like laser ablation has the potential because it's done in the office. It's simple, it's quick, it doesn't mess up your erections. These are the key things that make it difficult for a guy to come in, right? I don't want to go to the hospital. I don't want this huge bill. I don't want to lose my erections. I don't want to mess up my urination. If we can make the treatment for prostate cancer as easy as going in to get your teeth cleaned, then it becomes an every person's treatment and we can have a global and community impact. The problem with the big fancy technology driven, and I was the biggest robotics guy, is just that it's so expensive. And then you talk about radiation treatments and proton therapy, high food, they're great, but the problem is it's just too expensive. We need something cost effective, cheap, can be done in an office with a little bit of IV sedation or nitrous. And that's what this is. And this could really eliminate prostate cancer. Why is it the number 2 killer for guys? We need to get rid of it. It's you can detect it, you can identify it. There's no reason why it should be killing that many guys. Why is it that we're finding more end-stage prostate cancer now? It's a direct result of our apathy. Our guidelines, our current thinking of telling people, putting a value in people, saying that, hey, if you're below this age, it's not worth checking, or if you're above this age, who comes up with that crap? I mean, there is no age limit. Just like, I know Rachel Rubin, preaches about how we should do estrogen for every female patient, which I'm starting to do now. The same way, we should do a PSA for every guy at any age. There's no reason to not check it. Why? There's really zero reason not to check it. Because what if we find something, we can treat them with a laser, get them on with their life, and we make this a past kind of history kind of thing. So those are some of the future kind of goals and how I'd love to take care of patients, hopefully.
I got you fired up with that question. Well, thank you again for sharing your expertise. Always good to see you.
All right, great to see you too. And thank you for the opportunity. Thanks for spending time with me. Appreciate
You're
it.
welcome.
All right, take care. Bye.